Right. So thank you, Sanjay, for asking me to come and speak to a room full of surgeons. Usually it's just boring physicians in the room, so it's a big change for me. I feel that I finally made it. So thank you. I work here at Homerton Hospital. I see a fair number of sleep studies which are sent to us from the bariatric surgeons here. I'll talk to you a little bit about this. I have no conflicts related to this symposium. So these are the respiratory problems which are associated with obesity. I'm sure you know this already: obstructive sleep apnea, obesity, hypoventilation, asthma, and also pulmonary hypertension, slightly more rare. What are the mechanisms by which respiratory dysfunction occurs? By the way, if this gets boring, you need to give me a subtle hint. So yawn or snore, just to tell me that this is not going well. I left out all the data tables and stuff like that because I thought time's going to be running short and I don't want to bore you too much. But I'm sure you know already that chest wall compliance is reduced due to obesity. The diaphragm doesn't move as well as it should. You also get increased pulmonary blood flow, especially at the bases, and the compliance is reduced as a result of that. The airway resistance goes up, and then you can get asthma. You can get reduced efficiency of the muscles and VQ mismatch because you have more blood flow at the bases, but the lungs don't move so much, so there's less ventilation. And also, we've heard a lot about the inflammation that occurs in obesity today, and that also can lead to respiratory problems.
I'll tell you what, let me put them in there, full on, and then I'll bring them down to what you think is... You tell me what is good. That's like that, a bit more down.
It looks okay, doesn't it?
Yeah,
Yeah?
Leave it there. Thank you.
No worries.
Thank you.
So this just demonstrates what happens. I'm not going into the full lung function testing, but you can easily understand that in an obese person, the total lung capacity is smaller. That represents the tidal volume, the normal amount of air we breathe in and out. That goes down. The expiratory reserve volume goes down. That means there's less space to breathe out. And this all results in reduced capacity to breathe. The airway diameter gets reduced because of external compression and pressure. And this may reflect itself in features of asthma. But also there is change in the airway smoothness, and that also leads to breathlessness. So obstructive sleep apnea, that's the main topic today. It is seen in a large number of patients who have bariatric surgery. So it is quite a big problem, but it's not always addressed very much. But thank you to Sanjay for pointing out that this is an important topic here. What is it? It is partial or complete closure of the upper airways during sleep, and it leads to stoppage of breathing, which is an apnea, or reduction of the volume of the breath, which is a hypopnea, for 10 seconds, with desaturation accompanying this. A low oxygen and a high carbon dioxide level occurs. This triggers arousal, so sleep is disturbed, and this leads to fragmented sleep, as a result of which people then have daytime somnolence. They snore. Often their partners report that they have stopped breathing for several seconds before they start to breathe again with a snort, and this is a typical description. At this point, anybody who's still awake could look at their neighbor and see if they're snoring or having apneas, just in case. Unfortunately, obstructive sleep apnea in the long run causes arrhythmias, systemic hypertension, and pulmonary hypertension. So it then can lead to heart attacks and strokes. So it can be quite a serious problem if left unmanaged or untreated. I'll just talk a little bit about OHS, which is obesity hypoventilation syndrome, also known as Pickwickian syndrome, because of this character. Does anybody know his name? it's Joe, who appeared in the Pickwick Papers by Charles Dickens, and he was always sitting there falling asleep. And this is why it's called Pickwickian syndrome, because of the Pickwick Papers. So it is defined by hypercapnia in the daytime. So not just overnight hypercapnia, and in the presence of a BMI of greater than 30. We have to exclude other lung diseases or neuromuscular diseases which may cause hypoventilation, such as COPD, for example. People complain of tiredness, poor sleep, morning headaches. Up to 30% of hospitalized obese patients are found to have obesity hypoventilation syndrome. In most people with OHS, OSA is also present, so it's like 80 to 90%. However, the prognosis is good with non-invasive ventilation. I'll say a little bit about that. So, history. This is the Stop Bank questionnaire. It's a useful questionnaire to use as a screener. It's not that difficult. Once you get used to it, it only takes a minute to run this questionnaire by a patient. Do you snore loudly? Do you feel tired? Has anybody observed you stopping breathing in your sleep? Usually it's better to ask the partner these questions. Blood pressure, BMI high, that if they're in your clinic, they've got a high BMI, that's easy. Age over 50, neck circumference, male 17, female 16. And gender, male gender is more associated with obstructive sleep apnea. So intermediate risk is a score of 3 to 4, high risk is 5 to 8, but above 3, you'd probably want to do a sleep study. We'll come to that. This is the Epworth Sleepiness Scale. I won't go into it. You can easily find this. This is not a very good screener for obstructive sleep apnea. So I wouldn't use this to diagnose, but what this tells you is that if somebody is feeling very sleepy, they're going to score highly on the Epworth Sleepiness Scale, and they are more likely to accept CPAP treatment because they are getting symptomatic. And when they start CPAP, they feel better, their sleepiness levels go down, and they continue to use it. Then, examination. This is the Mallampati classification. Does everybody look at this? Do people look for this in clinic? Yeah, some people do. Only anaesthetists. So, you can see there's different grades there. You can see what it says, but typically, when we see people who have obstructive sleep apnea, this is what their mouth looks like. Interestingly, I sometimes see people who are referred to the sleep clinic to have a sleep study, and they open their mouth and they look like this. You can almost see down to their epiglottis. You know almost that they are not going to have significant obstructive sleep apnea when you do the sleep study. So it's interesting. This does tell you something about what's going to happen. Neck circumference, high neck circumference, it's this time in centimeters, just in case you don't think in inches. Enlarged tonsils and nasal obstruction may contribute. So we look for those things when we see somebody in clinic. Saturation of less than 92 will trigger blood gases to look for raised CO2 and hypoxia. So these are the tests, arterial blood gases. We do blood tests, obviously. You know this better than I do. So if you have these things, it is slightly more likely to lead to sleep apnea and hypoventilation. So these need to be corrected. Echocardiograms are often useful, particularly if someone has edema. 24-hour ECG if there's a history suggestive of arrhythmias, dizziness, palpitations, etc. Any concern about lung disease, we would do a chest x-ray, should be a basic screener preoperatively anyway, and then sleep studies. I'll come to that. So lung function tests, usually you get a restrictive lung function test. We get a lot of patients who are referred to the chest clinic saying, they've got restrictive lung function tests, have they got pulmonary fibrosis? But then you find that their BMI is 35, and that usually explains a mild restrictive defect, not a severe one. In severe obesity, FEV1 may be reduced as well. I mentioned briefly that the expiratory reserve volume goes down, but the vital capacity, that's the maximum amount of air you can blow out after taking a maximum deep breath, that is usually normal. DLCO is usually normal or high. DLCO measures how well carbon monoxide diffuses across the lungs and goes into the blood. So this is a sleep study. The gold standard is a lab-based polysomnography, and it includes all these things which are monitored overnight. So you're looking at the pulse oximetry, respiratory airflow. So we usually put a little sensor. It's just taped to the nose. It looks like a nasal cannula that you use for giving oxygen. And a little microphone we tape to the throat that detects snoring. We look at chest, abdominal, and limb movements. They wear these belts, which help to show how much they're moving. Body position, so supine versus lateral. Sometimes you find people only have problems when they're supine, and if they sleep in a lateral position, they're fine. EEG, electrooculogram, chin electromyogram are all things which are looked at in a full sleep study, as well as the ECG. However, a full sleep study is not always necessary. We don't do it at this hospital. We usually just do these channels, and these can be done in a portable setting, so people can take the machine home, put it on, they're taught how to do it, they bring it back the next morning, we analyze it later. So you don't have to have a lab-based polysomnography. These domiciliary sleep studies can be done fairly easily and can give you an answer pretty quickly. So the AHI is the number of apneas. Remember, apnea is where you stop breathing. Hypopnea is where the volume is reduced, and this airflow sensor will tell you that. If it's less than 5 per hour is normal, so even if you got 3 or 4, this could be normal. That means you could stop breathing for 10 seconds in your sleep, and that's still normal. If it's only less than 5 per hour. Mild, 5 to 15, moderate, 16 to 30, severe, greater than 30. But a lot of the patients who are for bariatric surgery tend to have severe OSA, which we often see in clinic. This is what the sleep study looks like. So you can see the microphone records the snoring intermittently. And then at the same time, you can see that the flow is interrupted. You get the movements of the thorax and abdomen increase. So while they're snoring, the chest and abdomen are moving, but the air is not getting through. And the saturations go down. And you can see that there's a corresponding rise in heart rate as well. So that's a typical picture of obstructive sleep apnea on a sleep study. So we look at these and then give you a diagnosis and an AHI, which then guides us with treatment. So CPAP is used to treat OSA. It has been shown to reduce hypoxia, it reduces tiredness, it reduces daytime somnolence, and can help with perioperative complications as well. Usually we recommend 2 to 3 weeks of treatment to reduce the AHI and improve symptoms. Usually we would say do that before surgery. There is not very good evidence for that, but I think a lot of people would say that if the oxygen levels are better, people are feeling a bit more energetic, they're more likely to do well with surgery. So it's a common sense approach rather than having a lot of data behind that. NIV is required for OHS. And just as a practical point, patients are advised to bring their machine to hospital, whether they're coming in for surgery or any other medical procedure, so that they can carry on using their device and keep their oxygen levels up. So just to highlight, CPAP is continuous pressure. It splints open the airway and stops the airway from collapsing. It doesn't work if there is no ventilatory effort, whereas NIV is actually ventilation, and it ventilates even in the absence of a respiratory effort. The machine is much more expensive than a CPAP. CPAPs you can get for about 200 quid or something. NIV machines are usually in the thousands. That's how CPAP works. So normally, a normal person would have good airflow during their sleep. In obstructive sleep apnea, the airway collapses, the air doesn't get through. But when you use CPAP, the pressure keeps the airway open and allows oxygenation. One of the common questions we're asked, in fact, I was having a discussion about this yesterday, was what do we do when patients don't tolerate CPAP? And this is a very common problem. There are many different masks available. Usually you'll find that CPAP centers will just give a standard mask. And this may be uncomfortable. It doesn't look very comfortable from here. But these are nasal masks, the ordinary nasal masks. They're still a little bit restrictive. Nasal pillows are less restrictive. They look a little bit less claustrophobic. Sometimes people mouth breathe. If you're a mouth breather, wearing a chin strap may help, and it stops the mouth from falling open. They're quite soft and padded. They're not uncomfortable. And sometimes then, if you encourage breathing through the nose, this means they can use a less claustrophobic mask. Even children can use these nasal masks in certain conditions. And you get these now fancy masks which are available. These are much less restrictive. So you can lie on your side, you can turn around, roll around in bed. It won't come off. It's very comfortable. It's like a very soft, it's like nasal cannulae, but they're much softer. So there's no pressure. Even if you lie on it, it doesn't actually hurt you. So sometimes these more expensive nasal masks may help when somebody says they cannot tolerate the CPAP. So it's worth trying these things. Another type of treatment is a mandibular advancement splint. So as you know, when the jaw falls back and the tongue falls back, the airway is closed, but these splints can be used to pull the lower jaw forward, and that stops the obstruction from happening. But people need good teeth for this to work. But then you can get custom-made advancement devices which can help in people who are absolutely unable to use CPAP. Throat surgical techniques are often used. There have been various things. Tonsillectomy, adenoidectomy may be a good idea if they are very enlarged. These are treatments that are used. They cut out part of the palate. Even things like partial glossectomy, which sounds pretty barbaric, but that has been used sometimes to try and help. Maxillomandibular advancement seems a very sort of invasive technique to try and get the jaw forward. But unfortunately, none of these techniques are very good for OSA. They're actually quite good for snoring, some of them. But then a lot of people complain of regurgitation of food and drink after they have these operations. So it may be, there may be side effects there. Bariatric surgery is an excellent treatment for obstructive sleep apnea. So we find that even a small amount of weight loss can lead to a significant improvement in the AHI. There was one study that showed 71% reduction. In keeping with my promise, I'm not showing all the data and all the papers, but take my word for it, there are references. Symptoms can improve significantly after various surgical procedures. Post-operative reduction in CPAP pressure may be seen, and even CPAP requirement may go away after successful bariatric surgery. If repeat sleep studies are done, you can show that there's a reduction in AHI and increase in oxygenation. However, it's worth noting that not all obstructive sleep apnea is due to obesity. So there may be some people whose OSA does not go away even after they've had successful surgery, and they need to carry on using CPAP or mandibular advancement device or something. So a few FAQs. When is an initial sleep study required? Would you do it on every patient who comes to your clinic? Who does it on every patient? Anyone?
We do it on stop bank 5 or more.
Very good. Okay, so you're going to use symptoms or a stop bank questionnaire. 3 may be a cutoff. If you want to use 5, I think if you've got very good clinical certainty, that's okay. But it's probably advisable to use some sort of screener rather than not doing it on anyone or doing it on everyone. What sort of monitoring is required post-operative? This is treading onto Dr. Mukhopadhyay's area, so I shouldn't say too much about this, but just to mention that continuous oximetry is advisable after bariatric surgery. ICU, they say, is not always needed. I think practice may differ across the country. So after you've had surgery, you've recovered, when would you do a sleep study again? Would you do it routinely? Who would do a routine sleep study in somebody after bariatric surgery, post-operatively? No one. Nobody would do it. Okay, very good. So usually, it's only if there are clinical concerns, weight gain, worsening symptoms, diabetes, high blood pressure. So if any of these things gets worse, or if repeat bariatric surgery is being planned, then it may be worth doing a repeat sleep study. But if you do a repeat sleep study after an operation, you find it's improved, that may be informative. Is it safe to use CPAP immediately after the operation? Who says yes? Who says no? No one says no. Excellent. Very good. Okay, so my conclusions are OSA is very common. Symptoms and stop bang questionnaire may help to decide who needs a sleep study. CPAP is usually advisable for 2 to 3 weeks before bariatric surgery. Bariatric surgery is an excellent treatment for obstructive sleep apnea, but not in every patient, so you have to be careful. Post-op sleep studies are not essential, but may help to confirm the situation. So, thank you very much.
Excellent presentation.
Thank you.
Thank you, and you're very clear about post-operative follow-up, and there's no indication for routine sleep studies. But would you keep them at a clinical monitoring at all from a sleep point of view in patients who have lost weight and symptoms of sleep apnea have resolved? Yes. Are they on your books for follow-up clinically? Or not?
So usually, because they've got a CPAP machine, yeah, they will always be on the books, okay, and they will be invited to come back. And at that point, of course, nowadays CPAP machines store all the data on a memory card. So you have an SD card in the machine, you take it out and you can read the data, you can see how many hours they've used the CPAP, what pressure was required. So the CPAP machines we use are auto-titrating. So you can see if their pressure requirement has gone down. So as soon as the CPAP machine detects if the pressure is required, and if it finds that the airflow is good, it will reduce the pressure. And if it then finds the airflow stops, it will increase the pressure again. And then that data is there on your memory card. So if you find that the patient no longer needs any pressure to keep their airway open, we'll then take the machine back. Thank you very much. So that's how we would do it. So at that point, we'd discharge them.
Pretty.
Do you give the same advice of 2 to 3 weeks of people who have got pre-tibial dermatitis and you're suspecting that they've got right heart hypertension, in other words, more severe forms of sleep apnea, because you see these patients who have got this pre-tibial dermatitis.
Yeah.
Very
I think yes. I think that situation is not purely obstructive sleep apnea. So I think at that stage you're looking at OHS and cor pulmonale. So we would then investigate for those things as well. So in that sort of situation that you're describing, we'd definitely say echocardiogram, consider other treatments. I don't think that giving CPAP for longer preoperatively is going to make much difference there. But it's the other things that you take into account. And this morning we heard about some patients who are actually not offered surgery because of their comorbidity. So I think you need to be careful about patient selection there as well.
And what about overnight oximetry instead of your
sleep study? Overnight oximetry can be used. It is far less sensitive. So I think an overnight oximetry by itself is usually not enough to confirm obstructive sleep apnea. So I think you do need to get the other channels of chest wall movement and airflow detection in order to confidently diagnose it. Some people may have other problems. They may have airway disease, neuromuscular disease. They may simply be desaturating because of OHS. So it's not that certain if you don't do the other channels.
But would you use that as a screening tool then for those who have sent? So we know that even with stop bang of 5, not all of them will actually have severe sleep apnea. You have used the oximetry.
Our problem is usually time rather than equipment. So time is the essence. So if you then do a screener with overnight oximetry and you find that it's not certain, then you're doing another study. It's actually quicker just to do a sleep study in the first place. And a lot of them will be negative. That's fine. But it's actually quicker just to do a full sleep study.
Okay, thank you.
Thank you very much.